So as we continue to understand the frequency versus the geography and distribution of diseases, it is important to understand also how these diseases truly spread. And so for that, we look at its transmissibility, this idea of passing something on to something else. Now, again, this doesn't imply that it has to be alive. So as a way to kind of compare this, we can kind of cover most definitions based on their source to their destination, right? And so we'll define things based on what they are. So if they are alive or at some point in time alive, we consider to be biotic. And if they've never been alive, so a rock, a stone, water, that kind of thing, this is what we define as abiotic factors. So it's not that they're not alive, it's that they've never been alive. So there's a difference between being dead and never alive here. So when we're talking about a transmissibility from something that is alive to another thing that is alive, so biotic to a biotic factor, this is considered to be transmissible, right? But this is also considered to be communicable, because communicability implies things that are alive. But also this means that it can be contagious, meaning that it's being transmitted from some living source. Now, this does not exclude the fact that it has to be a human to another human. This can pass on from a dog to another human, like, for example, rabies. So that means it's transmissible from something living to something living, so biotic to biotic, right? But it also implies that one of the biotic things was an animal, in this case a dog, as opposed to the other animal being us as a human. And because it can be passed on from a host to a living host, this can also be considered contagious, meaning that whatever they have will also apply to you. And so rabies was one of those examples of biotic to biotic transmission, but also a common cold is included on this, in which a person, your friend, your partner, whatever it is, can sneeze on you or cough on you and then also transmit that. Now, you can transmit things from one abiotic source to another abiotic source, but that doesn't mean it's a disease. So transferring boiling water in a pan is taking something that is not alive to something that is also not alive, and you're transmitting heat, for example. So that's what we call transmissibility still. Now, that's not necessarily anything to do with us, but that's part of that definition. But what if the transmission comes from something that has never been alive to something that is alive? So an abiotic to a biotic variation here. So technically here, this is still transmissible because it is passing something on to something else, right? And it is also communicable simply from the fact that it involves a destination of something that is a living host, right? So the examples that we have here, for example, is acquiring something like gangrene, so cutting yourself with a rusty piece of metal that has been left rusting, out in backyard, like a piece of car or something like that, or to something like fevers caused like from Legionnaire's disease, or even something like Legionella that could be transmitted even in the air or other unclean surfaces. Now, what if you transmit something from you as a host to something that has never been alive? And so this can be readily kind of transmitted like using the toilet, right? So that's water, never been alive. Toilet, never been alive either, but you're still transmitting something onto it. So you're the biotic factor, your toilet or your backyard or a tree is technically the abiotic factor. And there, not that a tree is not alive, but the dirt, that's what I'm referring to. So a classic case of transmission here, and it's something that could be potentially pathogenic, are in your feces. So plenty of organisms in there, like E. coli present there, or even cholera, or Vibrio cholera, I should say, could be part of that. So this is a biotic to an abiotic transmission, and then somebody else coming into contact with those feces because they were next to the tree or because they fell in a river in water, that's how they acquired the disease. Now, there are other types of diseases that are non-communicable, and in this case, not even transmissible, and which can occur from a biotic source to another biotic source. In other words, there's not really coming into contact with them. And this can be something as Still like a heart attack or diabetes. You don't look at somebody and they cough on you and suddenly you become diabetic, or again, you come down with a heart attack. So these are non-communicable diseases. So that's a whole different realm typically associated with medicine. That's not microbiology in this case. Microbiology usually involves that organism, that agent that is transmissible. In this case, there's plenty of non-communicable diseases out there, and that's a whole different angle on medicine, for example, right? So to kind of continue to kind of define this and explain a little bit more of the details behind this, the term communicability and transmissibility and something being contagious more than anything else kind of requires all of these. It requires both biotic factors. It requires the fact that it can be passed on from one source to another. And in this case, it involves a living host to another host. So putting all of those things together is what makes something contagious. But what makes it infectious? So infectious implies the transmissibility, but it doesn't require that it comes from another host. In other words, again, you can transmit an infection, you can transmit a pathogen or an agent from a rock or water, something that does not require another host as a source. The other piece behind that is that, again, infection implies that it requires colonization, meaning not only does it get transmitted, but it has to stay on you, okay? It has to land on you and it has to grow on you. And that's part of those definitions that we include as this part of transmissibility versus adherence versus its incubation period and its pathogenesis. So this is where all of these factors come into play. Now, that being said, we go back to this mechanism of etiology, for example, and our understanding that the environment has to bring us together for the agent and the host to truly come into contact so that disease can occur. And so we start dividing, for example, the differences between a communicable disease being through direct contact or indirect contact. And so here we start kind of subdividing how this particular agent or pathogen can spread from one another. So, or at least that's the idea, right? So through what we call a direct method of communication, the most common one here and probably the most obvious of them all is this idea of transmission occurring from one host coming into immediate contact with another host, right? So that's the idea, or at least with another agent at least. So you have to actually touch it in this case, it comes directly. Whereas an indirect transmission, in this case, is this transmission that is occurring in the absence of direct contact, as obvious as that sounds, and that usually means that it requires some sort of intermediary. Something else has to come in between to transmit that disease, or that agent, I'm sorry, not that disease, I'm sorry. So as we start kind of looking at these and start kind of understanding how disease spreads, we can start including some new definitions. So one of the most common ways, aside from somebody literally touching you, kissing you, licking you, whatever it is, that direct contact, the indirect contacts, on the other hand, requires something else in between. Okay, so that intermediate that I'm referring to. And so in there, we include the subject of a droplet, a term that you've probably heard a lot lately. And so the term droplet, its full or correct term in here is referred to as a respiratory droplet. And so this refers to fluids, liquids that are coming from the host that could contain the agent. Doesn't mean that it always does, but technically could contain an agent, like a virus, for example, or a bacterium, right? And so what's interesting about these droplets is that if they contain this agent and somebody's coughing or sneezing or anything like that, you can come into direct contact behind them simply because literally something is speaking to you, not someone, I'm sorry. And as they're doing so, those particles of fluid containing the agent come from that person, from that host, and hit you in the face, your nose, your eyes, whatever it is, and then you kind of rub them in. That's how you get that particular agent inside of you. So let's say direct contact with those droplets. Now you notice that I have these kind of under a little asterisk because there is technically a different version to acquire those from those droplets. And it's not necessarily a direct contact with the person that has the disease. It's simply because that person, for example, sneezed on a desk and then left it without cleaning, and you sat down at that desk and put your hands on it and happened to touch your eyes afterward, you still came into contact with those droplets. It didn't happen directly, rather that something that was placed and you afterward came into contact with those. One of the most common ways, for example, is a fecal to oral transmission, in which particles present in a toilet, for example, anything from urine to even fecal samples, which are contaminated, which are fluid pieces that are coming from a living host, come into contact with you. So this can be also considered an indirect access to those droplets. Now, what are the other versions that exist? Well, those droplets can be broken down into typically by sizes. And so usually the size of 5 microns is a measurement that we utilize. And so what we call respiratory droplets that are kind of smaller than 5 microns or less than 5 microns, they're referred to as droplet nuclei. So like the term nucleus, just a little bit smaller, right? Are usually kind of lighter, so in terms of weight and in size. And so respiratory droplets that are less than 5 microns usually can kind of float around in the air for a longer period of time. Now, it really depends how long. I know that that's usually a common question. So when somebody sneezes these droplet nuclei, how far can they get? And that really depends on the weather, to be honest, more than anything else, and technically how hard you sneeze or how hard you're speaking, if you will. If you're yelling at somebody, those droplets will travel a little bit further. If you're one of those people that are the stereotypical like loud sneezer that everybody in the city hears you sneeze, then those droplets are coming out with more force and definitely will travel a little bit further. The other aspect behind that, though, has to do with the current in the air. If you're inside a closed room with some AC going on, those droplets will definitely travel through the entire room and hit almost everybody. Okay, and so the distance that these tiny little droplet nuclei can travel have been usually measured anywhere between 6 feet up to 20, 30 feet in distance. So they can travel quite a bit, as opposed to what we call the respiratory droplets that are greater than 5 microns, so bigger than that. Usually these guys are a little bit more fluidy, more liquid in there. So that means they're heavier. And so those don't travel as much. And so usually those don't get beyond about 3 to 6 feet, which is where that number that you've already heard about has come from too. Now, most of them don't make it past, like I said, 3 feet or a meter or so in distance, but some of them can make it up to 2, so 2 meters, meaning or 6 feet here. And so keeping in mind that the size of the bacterium influences this, a respiratory droplet larger than 5 microns may include bacteria. Most bacteria are between 2 to 5 microns. That's what you measured in the lab. If, for example, a virus, a virion particle, more than anything else, is 1/10 of that. So there's tons of them that could be spread out in respiratory droplets that are bigger than 5 microns themselves. So here's kind of where this concept of wearing masks in this idea of social distancing kind of comes into play. This idea of it's not necessarily about you protecting yourself from others. It's that kind of idea of respecting other people's distances, and this concept that by wearing a mask, not only you're reducing both sizes of droplets, the droplet nuclei as well as the typical RDs, and them not traveling more than at least 6 feet or so. And so those masks truly make a difference in reducing that spread. And to the point that its efficacious transmission goes from being 80 to 90% without a mask to about 0.15%. So truly nearly 1,000 times more, less transmission by simply wearing masks between two particular hosts. So these droplets play a role, which is why you hear this out throughout our conversations about the disease. Now, mind you, again, these are done in lab situations, and so these are also average numbers that occur. So just because you are technically 6 feet apart doesn't mean that that's guaranteeing that 1,000-fold near transmission. It's the further apart you are, the better it's going to be. So please try and maintain that social distancing even beyond the 6 feet, even beyond the wearing of the mask. So that's the concept of masks and social distance plays a huge role. But more than anything else, aside from this kind of mode or method of transmission, your ability to wash your hands is also a big deal, right? So you are trying to decrease all sources behind them. Now, aside from respiratory droplets, what other things can, include the transmission of these? And so here we introduce a couple of other bits of terminology that you'll probably hear about. The most common one, for example, is what we call a vector, which usually involves another host. And here, what we're referring to is a non-human host most of the time. And so this involves something like a dog or a cat, a skunk, a possum, raccoon, all these animals. Notice that most of these are four-legged, that could be carrying the organism inside of it, both mechanically, so just as a way of transportation, or biologically as a way to kind of help them reproduce or grow or do something inside of them. So this is what we call the vectorial or vector type transmission, right? Now, the other factor associated behind this is what we call the vehicle. And so that means some sort of physical reservoir containing these. And so those can be divided into things that are growing in water, for example. So this becomes waterborne, or if it's inside your food, this becomes foodborne or airborne, and so on and so forth. So this is this kind of concept of transmission through a vehicle itself, right? Now, what about a fomite? Now, this is another term that you'll kind of hear a lot. And so fomite is the term to saying something that is abiotic, so something that has never been living, okay, that can be a source of an agent. So meaning that something that carries the agent and can transmit it onto you. So this means anything like your kitchen drawers, your kitchen sinks, your tables, desks, anything that is, again, abiotic that could contain the agent and could transmit it onto you. Now, since we're focusing on the SARS-CoV-2 virus over here, one of the other things to, again, consider more than anything else is truly how far can these things go? And plenty of studies out there, plenty of things you can actually refer to. I'm sure there's lots of cool little graphics out there kind of talking about the differences between certain things that truly can become airborne, not that they are a vehicle as airborne, for example, and the differences of this mode of transmission that involves droplets. And so the idea here is that plenty of studies demonstrate that just speaking itself, so just you breathing and transmitting things through your nose and your mouth, can make it up to about 6 feet or so. So again, that's usually the minimum distance that you see there. But what about coughing or sneezing? And so sneezes, which is a very interesting concept of exposing things up to 20, 30 miles per hour, if you really want to think about the strength that is coming up there, in this case can travel 20, 30 feet. So truly that social distancing plays a massive role, as well as your ability to cover your mouth when you're doing so. That's something I'm sure most of us are familiar with, but also using those masks, regardless of whether they're medical use or not. They will still make a huge difference. Now, that being said, again, other organisms not related to, in this case, SARS-CoV-2, are still methods to transmit things. So like I said, your water, The same water that comes out of a river is a vehicle for certain organisms, right? Or anything from you eating, some bacon or some sushi that contains organisms that weren't well cooked and then ultimately can end up inside of you. So these are abiotic factors that can be carrying the particular agent that could be infecting you. Whereas the biotic versions of these, in this case, involve some sort of living host, usually acting as an intermediary, and either one of these guys can act just solely for transport, meaning it's just kind of hanging on it until it lands to its destination. So we call those mechanical vectors, versus something like malaria, for example, that part of its reproductive cycle occurs within the mosquito itself. So it's considered to be a biological vector. So in this case, excuse me, the intermediary host is part of its reproductive cycle. It's part of its life cycle, and so therefore it's contributing in terms of its growth and its development. So that's what makes it a biological one versus a non-biological one, or a mechanical one. So when we go back to the wonderful disease that we're kind of currently dealing with, one of the key features that we started noticing is that this disinformation that started occurring kind of ran out of control simply because of the fact that we didn't really give it the importance that it needed to have. And so from December to the current state of now, and even now, as you'll hear from often certain sites and certain media, is that people still don't believe this is real, and people kind of downplayed it, and everybody believed that it was going to be small, that it was going to be under control, and there's nothing more ironic than kind of watching lots and lots of media out there, especially cool movies of people telling you the warnings, especially scientists telling you that this can be bad and this will become bad, and nobody's listening, right? So now that we currently are in the middle of this, it's a little bit too late. And probably one of the things that we could have prevented, for example, is by just paying attention to how we vote. And one of the things that I will kind of mention behind this is the lack of funding that occurs towards healthcare. And so just even altogether from hospitals not having the right amount of funds to be able to handle these things. But keep in mind that just in the last 4 or 5 years, the CDC itself and the National Institutes of Health have lost millions and millions of dollars in funding. So part of your votes kind of change those things. As now as we start experiencing these and realize that these kind of impacts of you being locked at home and running out of toilet paper too are a big deal, perhaps this will kind of change our perception of what science really is and medicine, so that we can put more funding towards these things, so that we really kind of need to listen to our experts and kind of support them in terms of protecting us. Now, part of that comes from the fact that we already knew a lot of this information. And so the only reason why we know some of this is simply because we've experienced 2 smaller waves, although more dangerous waves, of a similar but related types of virus infections and epidemics. And so like I mentioned before, these have occurred kind of in waves of roughly 10 years or so, in which we know that there have been what we call spillover or zoonotic transmission between one animal to another animal to eventually us. And one of the reasons why the previous 2 sets of epidemics that occurred, even though they were more deadly, in this case, they killed more people in terms of ratio as opposed to totals. Currently, more people have died behind this one, right? But the issue here is that they were stronger, they're more deadlier type of virus, they were more virulent, the term that we're using here. But because we had a better understanding, because we knew about the animals that transmitted them at that point in time very early on, we were able to close down borders faster. We were able to shut down locations faster. We were able to perform what we call culling of animals, in which we kind of find those animals and unfortunately kill them, right, as a way to kind of remove them from this, right? And so this current one, a kind of cool little looking cat-looking thing that is more of a mongoose called a civet, is was the kind of originator of the transmission of the original SARS that occurred 20 years ago or so. It appears that dromedary camels happened to be the second one, and it appears that the closest thing that we had this transmission occur from bats currently into what we call pangolins, which are the coolest looking animals I've ever seen in my life. They look like little walking dragons, I swear. Are the current kind of spillover events that eventually made it to humans due to be coming into close contact with them. Now, the issue here is that the disease and its method of transmission and its kill rate is what's allowed this one to spread out a lot more than the previous ones. Remember that the success of a virus is largely dependent on its ability to transmit. MERS, for example, which had, as you can see up there, a case fatality ratio of close to 35%, meaning it killed 1 in 3 people. Think about it that way. It's not going to transmit very fast if you're killing everybody. But having a transmission, a death rate that is much lower, then permits it to spread. And so here's kind of where this kind of disinformation aspect kind of kicks in. And a lot of what the media currently reports is largely based on 2 factors. And so they report, and this is the so-called, you'll hear this term called R naught, or R zeros, or R null are the terms you'll hear a lot in this case. And then the CFR, which is the one we just mentioned, which is called the case fatality ratio. And these numbers get reported all the time, and they're truly used as kind of fear tactics, because most people end up misusing them as well, because both of these numbers, one, are not really set in stone. They vary dramatically based on lots of factors. So to report them out as these kind of static numbers and say, that's really scary, is just a form of misinformation and disinformation. They're scare tactics. And so the more you understand what these terms really mean, the better it is for you, right? So what I like to do is kind of give you an idea of how these numbers really work, so you can kind of understand what people are trying to report behind this, right? So first of all, let's kind of get an idea of scale. For those of you who remember kind of the replication of viruses, as opposed to a bacterium, which may take a couple of hours to maybe a day to replicate, and humans taking, somewhere between 15 to 20 years to do the same thing and make another copy of itself. Viruses usually occur within a matter of, 20 minutes, maybe 30 minutes. And so if you have a virion particle, and it, makes 100 of itself every single time, each cycle, if it goes between 20 and 30 minutes, you go from 100 to 10,000, right? So, and then ultimately every hour to 2 hours to 3 hours, by the time you reach the 4th or 5th hour, you're now in the trillion of virion particles. And all you really need is one of them to spill over. All you need is one virus to go from one organism to another organism and find its way to do so. Now, the problem with it, depending on who you ask, depending on which researcher, depending on which virologist, we currently estimate that there's somewhere between 2 to even 5 million different viruses in the wild that we haven't really discovered. And that's not even counting the ocean, just in case you're wondering. So all we need is one for it to spill over, and these are replicating in extremely high amounts. So the chances for this to occur is relatively high. It's relatively expected for those of us that were in the field. Now, to again explain the intensity, the impact that these things have, it's kind of really important to understand what these numbers mean. And so number one thing that you'll always hear about this virus, or any virus altogether, is its CFR, or case fatality ratio. Now, what are they trying to tell you here, so you make sure you understand that, right? These numbers, one, first of all, I want you to understand that they're highly inaccurate and kind of very difficult to assess, especially at the beginning of a epidemic. And don't take me wrong, but this has just started. Okay, this epidemic, even though we're now getting into roughly around 8 months of this occurring, it really hasn't had its chance to truly kind of spread out as much as you think. So when this first started, when we first kind of gained notice of it early on in March, numbers started popping up, and these calculations were starting to show off, and people were reporting all these crazy numbers, and most of them, they're showing you these really high death rates and everything else. And so again, misinformation, disinformation, just so that people can claim we're the first or come watch our channel kind of thing, led to a lot of scare tactics more than anything else. And so kind of let's explain to you in a very, very simplistic way on how the CFR really works. Again, it's a ratio, so it's a calculation, okay? And so when somebody that is a non-expert kind of uses them, it can be misused and, again, cause a lot of panic. So I give you a very simplistic way of math that I can show you, right? And so let's say we have a confirmed set of cases that are 500 people, right? So we know for a fact there's 500 people that got infected, okay? We know for sure because they had a cough, they had to have fever, and we did some awesome tests, and we know there was 500. And then we find out that 10 of those people died. So if you do the math, the case fatality ratio is 10 divided by 500. Okay, that's all it is, okay? So if you do that number, okay, that's 1 in 50 or 2%. That's all it is, okay? So now you're reporting that this disease has this capacity to kill 2% of its population, of whoever it infects. But what happens if the following year, okay, we get another 500 people that get infected, but no more deaths? Well, now the case fatality ratio literally got cut in half. It changed from 2% to 1%. Now it only kills 1 in 100. Now, what happened? Why wouldn't there be any new deaths? You see, the issue behind most diseases, especially with viruses and respiratory viruses or anything else, is usually at the beginning, we get a lot more deaths. That's usually when we notice them. Usually the weakest people die. And I'm sorry, I'm sounding kind of a little elitist about this, but usually our weakest humans go down first. Same concept behind, your classic Lion King-ish kind of thing of your cheetah eating the weakest gazelle. Same concept. The disease will take its toll first on those who have a weaker immune system, those that are young, those that are older, those that have undergone surgery, those that are immunosuppressed, those that have all these other confounding factors that make them weaker and more likely to die. So right at the beginning of the disease, lots of people died. And so it looks like its case fatality ratio is much higher than really what it is. So unfortunately, when the news just said, 10 deaths occurred in 500 people, that number became 2%. But as time progressed and we continue to live and less people die over time, the case fatality ratio changes. So it's not a static thing. And so we won't really have an accurate number for the case fatality ratio until years after this has passed. I will be surprised if we can predict a really good case fatality ratio if it doesn't happen within about a year to two at least. So for now, though, whenever anybody's reporting this information, it is going to cause a little bit more panic. So this is why we don't really want to take that CFR as this kind of critical number that everybody likes to report in the news. More than anything else also, since it's based on a lot of factors like age, it's not just one number. There are ranges. And as most of you probably have heard by now, for example, usually people that are above 55 to 60 have the higher risk. There's a significantly higher CFR in our elderly population than there are in the rest of the population. So Because of those numbers, we can't just report one number. But anytime you see this in the news, they'll just say, it has a CFR of 10%. Yeah, it's kind of scary if you hear that. That's 1 in 10 people will die. But that's because, again, they're just averaging out numbers, and we're still getting the data placed in there. So we're way ahead of the game right now by trying to report these. So we kind of need to wait. We're still kind of, we don't have enough material or data to truly start predicting these numbers accurately. And that's just one of them. The other one that gets reported is even worse. And so for this one, this is called the R naught that I mentioned earlier, called the basic reproduction number. And one of the things that I want you to pay attention to, that term, to that name, is literally what it says. It says basic reproduction number. Notice that nowhere in there does it say rate. Notice in there that nowhere in that definition does it say how fast this occurs. The problem with it is that when people report the R naught, they treat it as if it was a rate. They tell you, oh, well, it's happening this fast. No, it's not. This has nothing to do with time. Okay, this is not a velocity thing. This is not an acceleration thing. This has nothing to do with time itself, but it's often treated as such. So we have to be very careful when we look at that. So let's look at R naught, kind of what it is. This basic reproduction number is fairly complex. And the other thing is that it also gets kind of oversimplified too often. So that kind of people just assume that it means how deadly something is and how fast it spreads. When in reality, people just treat it as, oh, how many people get the disease, just so that it can make sense to the common kind of lay, everyday person that has no expertise in epidemiology. So you guys get to be those healthcare providers that get to explain this correctly, okay? So the other factor very similar to the CFR is this number is also highly inaccurate and highly variable. So people kind of simplify the formula for R naught by pretty much saying, look, this R naught represents kind of how many days somebody's infectious by how many people it can infect or that person comes into contact, and what's the likelihood that somebody will get an infection. Remember that even the term infection, it means that not only does it get transmitted, but also lands and it stays and it causes disease. All these other factors that need to be considered. So how long is anyone infectious? For example, one of the bigger concerns you should have here. And you should understand that that number is incredibly variable. You can't use an R naught number that has an incredibly high infectious range. I want you to understand, think about this. Some of you have gotten sick and passed it on to your cousin, mom, brother, whatever, and they got sick and they got sick faster and probably lasted longer or quicker than you. And that's just somebody that's related to you in your family. How long somebody becomes infectious kind of really varies from person to person. Your immune system plays a huge role. Some of you may be able to clear out the disease so fast that within a day you stop being infectious, or contagious in this case too, the other term we can use. But there are some that their immune system is not that well developed, or that's just not as good. And in this case, they continue to have a higher viral load, a higher amount of the disease, of the agent, not the disease necessarily, and they can transmit to other people for longer periods of time. So how long is that infectious period in reality? That we still don't know. Again, we have ideas, but we really don't know what that first number is. Now, keeping in mind that we are measuring under R naught how many people will get infected when they come into contact with you. Okay, that's a good number to know. So when people talk about these numbers, the examples that we're showing you here, and I have two ways of kind of demonstrating it and visuals, is that, for example, your classic cold, your good old flu H1N1 typical virus, at least the strain that is not that horrible, right? It has this so-called R naught factor of a 1.2 to 1.6, meaning roughly speaking, when one person comes into contact with others, about 1.5 people get infected. Now, I know the half person sounds kind of weird, right? But I get it. But when they reported it for SARS-CoV-2 or COVID-19 specifically, they're currently still reporting somewhere between 2 to 3, and I've seen even numbers higher as 5. But that's, again, how many people become infected when they come into contact with you. Okay, so if that's the number we're going to report, now tell me, how likely are you to infect 2.5 people, let's just say, if you live out in the country? Meaning you're on an awesome farm in this wonderful open area with cows and donkeys or something like that, and you don't have another person for another 50 miles. You think you're going to spread it out to 2.5 people in the same way that if you live in downtown LA or New York. That number changes based on location, and it changes based on how many people you come into contact with. So how can you estimate a number that is highly variable? Even living here in our area, our chances of coming into contact with people is significantly lower than if we lived in LA. So the number that is affected with how many contacts you have, how many successful contacts, also changes. This is called the effective contact ratio. So the effective contact changes where you live. If you live in LA or metropolitan areas or urban areas, that contact number is much higher. If you live out in the boonies, for example, you may not come into contact with people too often. So how do you get somebody a number that is highly variable? Now, we've now already included 2 factors that are kind of erroneous. How long can somebody be infectious? And how many people are you coming into contact with? 2 numbers that are already highly variable. What about the third number that is included for this? The infection rate. How infectious somebody is. Okay? So to calculate an infectious period, believe it or not, it takes years of calculations to do so. You can't just use, a couple of months worth of data. Okay? So in order for us to truly account how infectious somebody is, we truly need to kind of account for all the infections that have taken place, and that all of the ones that became, that recovered, that were either cured or treated, convalesced, and so on and so forth, and how many others were infected after that fact. In the last just few months, we don't have the ability to calculate that number. Again, we need years worth of information. And again, remember, based on the fact that it takes a calculation of how many people we come into contact, as well as, again, how good your immune system really is, the infection rate is also a highly variable number. So the 3 numbers that are used to calculate the R0, the basic reproduction number, are all highly variable, and they take a long time to calculate. We've now had a good, say, solid 5 to 6 months to calculate this, and it's not enough information. So why are we giving out people R0 numbers? Obviously, the higher the number, the more people get infected. So when we report an R0 that is inaccurate, as it still is, people are going to freak out. For the same example, now, if you see in the middle of the chart, you'll see that, for example, when measles is reported, one of the best studied viruses in this case and diseases, it is insanely contagious and insanely infectious, right? So one person can give it to almost everybody that is coming into contact, depending on the population, right? So, but we only know this because we've had hundreds of years to actually estimate that number. Not 6 months, not a decade, centuries. And notice that even under centuries, we still have a range of between 11 and 18. So why are we trying to estimate this for SARS-CoV-2? We really can't estimate that yet. We need a lot more time and a lot more information. However, to kind of truly demonstrate how crazy this gets, I wanted to do a little bit of math with you guys. And so I kind of wanted to show you kind of what this looks like in an actual case-to-case scenario, right? So I'm going to show you kind of a very simplified version of this, kind of showing you what we have with one sick person, which I'm sure you can tell which one it is, right? And who's kind of hanging out next to 5 people that are kind of currently uninfected, right? So the idea is, let's kind of label them as infected people. So let's make them cases. So these are people that have become positive for that particular virus and that particular disease. So that's kind of what we're going to go with right now. Now, what we're going to do is take those 5 people and give you 4 different scenarios of what CFRs and R naughts really mean. So to kind of show you this, I have 4 scenarios in columns, column 1, 2, 3, and 4. So 5, 6 people right there. Now, what you're going to see here is just a very simple kind of idea of doing a little bit of simple math, if you will. And we're going to say, we're going to ask how many cases there are. Okay, so there's 5 cases, right? And then we're going to ask how many new cases occur. Okay, so there's our 4 different scenarios here. So in the first scenario, the first column, column I, okay, or column 1, there's 5 cases and 2 new cases were generated from them, from 2 other people. One person spread it to another, one person spread it to another, and then the rest didn't spread it to anybody else. Okay, so this case of 2 over the 5 original ones gives us a very kind of rough number of 40% or 0.4. Now in scenario 2, we have the 5 giving it to 5 people. Scenario 3, we get the 5 giving it to 9 people. And then case 4, or situation 4, I should say, we have 5 people giving it to about 75 people, right? So I had to make a lot of smiley faces here for this to work, right? Now, depending on which one you do, you can kind of get an idea of how much things spread, right? The 2 out of 5 didn't spread that much. The 9 out of 5 was nearly doubling in terms of how many people got infected. And the 75 out of 5, really 15 times more people were being infected per each individual person, right? Now, when we calculate this simplified version of R naught, okay, we end up with a 0.4, a 1, a 1.8, and a 15 respectively, right? Which, again, the higher the R naught, that means they're suggesting that it spreads more, okay? So the problem with this is that this is a lie, okay? These numbers that you're being thrown at is not really what it means, because nobody's taking into account time. You need to understand how fast something spreads for it to be a concern, okay? So it's not about how many people you can infect, it's how many people you can infect over time. That's the biggest concept, and R naught does not give you time. So now let's give you some time, okay? Give you the same 4 cases that we just gave you, 0.4, 1, 1.8, and 15. And now let's give you actual information. So you see, when we looked at, for example, MERS, the second wave of the coronavirus-related diseases from those organisms, okay, MERS had this ability to spread every few days. Whereas your classic seasonal flu also does the exact same thing. However, diseases like Ebola and HIV, which have twice as much, if not a little bit more, the ability to spread, a higher R naught, take decades before you can actually see this. Decades. Remember, in terms of HIV, that transmission takes years, if not decades, for that to spread out. Ebola just takes a few days. 2 significantly different diseases that have the exact same R naught. How do you compare an R naught of 1.8 and just say, oh, they're the same disease? You can't. That's the issue, right? Most people are just kind of abusing this number. Let me give you a different scenario, which a significantly higher R naught is included, and has nothing to do with decades. This spreads out like wildfire. I'm sure some of you have been victims of this. Things like measles and chickenpox, right? They spread out like no other. And this is in a matter of weeks, okay? So to truly kind of gain a better understanding of how R naught works, is that we really have to have the concept of a time frame. Just saying that it has an R naught of 2, like Ebola and HIV both have, doesn't really give you an idea of how bad it is. Okay, so HIV, as we understand, which is a very serious disease, spreads out from every one person to 2 people, but it takes a couple of decades to do so. It's still a very dangerous virus, and it's still a very dangerous disease, but it takes forever to do so. So that means more chances for infections and a very slow chance behind how the disease affects them. As opposed to Ebola, also takes out 2 people, but it does it in a matter of days. R naught is not the number that you're looking for, nor is the CFR. These are numbers that take forever to calculate. Now, you want to have some really good information, use a different number altogether. This is called the serial interval, not the series interval. That's a math thing, so be careful. Okay, the serial interval here is a number kind of is used to determine the period between one infection and the next one when the first patient displays symptoms. In other words, what's the amount of time between the first person having symptoms and the second person having symptoms? Okay, so the idea is that difference in time between one person to another is what we call the serial interval. Okay, so here what we're trying to look for is the time between the onset of signs or symptoms between one case and the subsequent case. Okay, so pay attention to this number because this is going to make a lot more sense than what it means over here. So now let's look at it from the source of scale, right? So to understand really what this means, we're going to look at, again, that onset of that serial interval. Not series, serial. Don't forget that part. Okay? So here what we're seeing, simple concept of, we'll take one infectious case, just one person over there, the little dude in blue over there, okay? And so blue, green color, whatever that might be. And we introduce that person into a susceptible population, so people that can be infected, of, let's say, 1,000 humans. Okay, let's throw 1,000 people in there. If this agent has an R naught, okay, of 3, so one person spreads it out to 3 people. Okay, that's what that kind of fake number that I'm trying to make up over here that I'm trying to dissuade you from using is. Let's say make it 3. But it takes 7 days for it to occur. So the serial interval is 7 days. So each step that we're seeing here is day 0, day 7, day 14, day 21, and day 28, okay? If this has an R naught of 3, in other words, an average of 3 infections per case, which means it's spreading rather quickly, or at least it seems, if we look at the math, this is where things change. I want you to understand the math. So now that person got introduced to the population, and that person infected 3 people, and then those 3 infected 3 more, those 3 infected 3 more each, and so on and so forth. So what happens? If you kind of take this and do it just mathematically, on day 1, there was only 1 person. On day 7, there was 3 more people. On day 14, 9 more people got infected. On day 21, 27 more people got infected, and so on and so forth. So how do you calculate this number? Well, what's the official numbers? You actually kind of have to tally them all. So that 1 plus the 3 plus the 9, that's 27 and the 81. So basically 120 new cases if you kind of add up this math over here, right? Out of the 1,000 people that were exposed. Now, 120 divided by 1,000 is about 0.012. And so over the period of about 28 days, I just rounded up to a month over here, we actually get an interesting calculation, okay? In other words, what we're seeing here is that roughly 12% of the population got infected in over about 30 days, meaning 4 cycles of serial interval, okay? It's not just 81 people got infected, it's the 81 plus the previous 27 plus the previous 9 and so on and so forth. And that's assuming if we're only looking at the R naught. But now let's just change it. Let's take a look at serial interval as opposed to just the R naught. What if we change the serial interval to 3 days instead of 7 days? So now we shorten the number. Same R naught of 3. The R naught is still the same number, just the distance between one set of symptoms to the next has changed. Well, now, every 3 days we get 3, then 9, then the 27, then the 81 that we saw before. But then the next 3 days we get 243, the next 3 days we had 729, and so on and so forth. Now, if you do that math, I want you to understand that instead of being 12%, which is the number that we looked at last time, okay, now the factor that you're looking at here is 240 times many more people have been infected. Not 0.12, 240 times. If you want to understand this, it's at the end of the month, there'd be 30,000 infections. Not 120, like we saw in the serial interval of 7. So it's not the R naught. The R naught in both cases, from this one to the previous one, is the exact same R naught of 3. But it was the serial interval that changed. The period between one set of symptoms to the next set of symptoms of the other person. And cutting it down by half literally changed its craziness factor of only 12% of people got it, 1 in every 10 or so. Yes, 1 in every 10 or so, to everybody and their mother got it, and worse, simply by changing the serial interval. This is where the issue lies. Is to truly understand how these numbers work, we can't just report R naughts. We can't just report CFRs. We really have to understand far more complex math than there is. And nobody ever teaches you these things. Okay, so this is important that we take into account the serial interval. So what's really kind of the moral of the story is that we kind of truly understand what the serial interval really means. So we want a longer serial interval. The longer it is, meaning the longer it takes from one person to the next person to display symptoms, the slower the spread is, right? And so here we're kind of displaying a quick table of R naughts. They're extremely all similar. So 1.8, 1.65, 1.8, and so on and so forth. Similar serial intervals to one they actually change dramatically, right? And so the current concept that we're experiencing here right now is that the current serial interval of COVID-19 seems to fall somewhere between 5 to 8 days or so, which is good. The longer it takes to spread, the better it is. The slower it's spreading, the better we can control it, as opposed to some of the ones that have occurred in the past that spread like wildfire and 50 to 100 million people died. Okay, so this is kind of where the moral of the story really kicks in. Depending on what type of serial interval you have, that it'll kind of really reflect how fast a pandemic takes place. A lower serial interval with a higher R naught will spread out significantly faster than a higher serial interval in this case, and a lower R naught in this case. So it's important to combine both. The amount of spread, but also the amount of time that it takes. That's where that SI truly comes into play. So it's important that you kind of get the picture from everything. So how is this kind of an important number for you guys to know, especially in the field of healthcare? Well, the idea behind most disease is we want to stop it, right? So how do you prevent that spread? How do you reduce or change that R naught? How do you affect it? How do you change that rate of spread, both the serial interval as well as how many people come into contact and get infected? Well, the most common way that we can talk about this, and this is something you already know as microbiologists, is that you have not only properties, but tools to change this, right? So pandemics, or for any case in point, any transmissible disease, become more effective when they have a shorter or lower serial interval and a higher basic reproduction number, or R naught. So logic would tell us that if we can increase the serial interval, meaning we can increase the time between the first set of symptoms to the next set of symptoms in the second person, we can actually slow down, not necessarily stop or cure, but at least slow down the progression of the disease. So before we really understand the disease, we can really just understand the math behind it. And so remember, R naught is how much it spreads. Serial interval is about how fast it does it. So we can change these numbers by something called an effective contact, or EC is the term we're going to use. So if we want to reduce the R naught versus SI kind of effect, we have to reduce the effective contact, meaning a smaller amount of people coming into contact, the smaller the R naught, meaning the less it spreads. And that should be almost logical to come into play, to saying the less people you come into contact, the less people you're going to infect, right? It seems fairly straightforward. So how do we change that? So what we can do are some pretty simple basics, right? So this kind of often gets not very well considered, but could we even eradicate this disease? Okay, so how do we make the R naught become 0? Not 3, not 2, not 2.5, not even 1. How do we make the R naught become a 0? Meaning we eradicate the disease itself. Well, the first concept is to block transmission, to stop it. So if there are sick patients, meaning cases, isolate them. You isolate the patient, they're not going to come into contact with anybody else. I know this sounds very simple and straightforward, but these are things that people are not considering. Now, how do you do this with people that work in healthcare? Well, how do you prevent every single nurse and doctor and healthcare provider on the planet from getting sick? Protect them, give them gear. So this is where PPE comes into play, the very first thing we taught you in the lab. Put a lab coat, put some gloves on, put some goggles on, and now put some masks on. Okay, so masks, even though they're not the best thing, currently the ones wearing cloth, it's still a really effective mechanism to prevent spread. So protect our healthcare providers, protect yourselves. You guys get to be those. So one of the easiest ways to make that R naught smaller, isolate the people. I should say isolate the cases, not the people. Isolate the cases, and then protect the healthcare providers. Now, further down the line, we can also prevent transmission. We don't want more people to get it. How do you prevent other people from getting sick? Well, probably the number one way we've done it effectively on this planet, and we have plenty of evidence to show that, vaccination, right? Depending on the efficacy of the vaccines, most of them stop transmission. And we will deal with this when we learn this in immunology, right? But if vaccination, it may not be an option, as we are learning lately, right? We'll then reduce the crowds, prevent the transmission, right? So reduce the effective contact. What is that called right now? Social distancing. It's the same concept. You've been hearing this forever now, but there's a reason behind this. You can change the R naught by simply just not being around people. Now, you used to hear it being called flattening the curve, right? So for a while, that was the concept that popped up for about a good month and a half, when people kept on talking about examples of what happened in our past, right? And one of them had to do literally with our previous flu pandemic, right? So what we want to do is do both. Not only isolate the cases, protect our healthcare providers from preventing, allowing more infections, but also prevent any additional cases. So vaccination will be next. We haven't gone that far, but until we get to the level of vaccination, we need to reduce the crowds. So what have you heard so far? And everywhere in the world from all the experts, put on a stupid mask, make a fun one because it makes you look cool, protect yourselves, and stop gathering. Stop going to somebody's birthday because they're your cousin. Stop saying because they're related to you, it doesn't matter. You literally stay at home. You don't leave your place. You leave for emergencies, you leave for important cases, leave for dire need, not just because you're bored at home and need to go to Walmart. It's not worth it, because all you're doing is changing that R naught. And you, as healthcare providers, are the responsible ones for that. So keep that in mind. So what we're going to do next, though, we're going to show you how to do that math. We're going to give you scenarios in which we can show you how effective PPE, isolation, crowd reduction all come into play. We're actually going to do this mathematically. So that's our next step.